Dr. Hurtle introduced himself as Dr. Lego, and I think many of us try to be Dr. Meccano. My job this morning is to put it to you that many of these fractures don't need an operation. In fact, may be better without an operation. There's always a spectrum of these fractures, from the relatively simple to the oh my God fracture. A number of these we could manage non-operatively. Some of these would be better managed operatively, and some of them, if we manage operatively, we may make things worse for the patient. Here's an example of an 80-year-old lady who owns a very naughty dog. The very naughty dog pulls her over and she lands heavily on her left arm. She's relatively elderly, so she doesn't put her hand out in time to protect herself, and she sustains this fracture. And this is a fairly typical X-ray appearance from our emergency room, where it's not exactly clear what's going on. She was managed by one of my colleagues who trained in Calgary and had very good service from him. At 2 weeks, after there'd been some traction in the collar and cuff, these were the X-ray appearances. At 2 months, it had healed, and these were the X-ray appearances. 2 years from injury, after extensive physiotherapy to get her shoulder moving, she's now 82 and is very delighted with the results. She has minimal pain. She just gets a little bit of ache after using the arm. She has about 80% range of movement. She can do all her activities of daily living, and she has no restriction in her leisure activities and the things she wants to do. This lady is a very important person. She's my mother, and she was managed by one of my colleagues. And if I allow this non-operative treatment for my mother, maybe I should be doing it to many of my patients. So the objective of this talk is to look a little bit at the pathology, to understand some of the limitations of fixation, to understand a bit more about non-operative treatment. Obviously, it's a personal view based on my experiences as a consultant in the UK, and there may be differences in philosophy around the world. And we'll try and allow a little bit of time for questions, or if you want to make an interruption during it, feel free. To operate or not, I think we have to ask ourselves a number of questions, which I've listed here, about whether it will make any difference for the fracture. And probably more importantly, will it make any difference for the patient? Can we do the operation? And if we can do it, can we do it well or acceptably? Or maybe we'll do it rather poorly and not help the patient. And if we do operate, can we manage the complications? And there are complications of fixing these fractures. If we're going to do it non-operatively, can we do that properly? And can the patient cope with non-operative treatment? Non-operative treatment often involves slings and immobilisation, and possibly in the medium term a more prolonged period of discomfort than fixation, where you may get a short period of more severe pain, but actually the pain settles down quite quickly. And perhaps we need to ask ourselves, how many of these are we letting ourselves into to actually fix? The various literature from around the world, particularly from Finland and from Mike Robinson's group in Edinburgh, suggests that the incidence of these fractures is increasing, that as you get more elderly, it becomes the most common fracture around the shoulder girdle. As I say, Mike's group have shown over a 15-year period a twofold increase in these fractures, and that with social deprivation, the fractures tend to be worse and they have more complications. And there is a mortality associated with these fractures in the same way as there is for hip fractures, of it being part and parcel of an elderly patient with comorbidities and other issues, and a sort of failure of protective responses. Does fixing proximal humeral fractures work? Well, there's a number of studies around. This study here from the Journal of Shoulder and Elbow Surgery really suggesting that, first of all, that there's not much out there to base our opinions on. The studies are rather small, they're rather poorly controlled, a lot of them weren't double-blinded, but nothing to really suggest that there's good evidence for fixing these fractures. And indeed, if you do fix them, there's quite a high complication rate. In orthopaedic trauma directions, which I think many of you will have had in your packs, there is quite a nice little review looking at a couple more small randomised controlled trials, picking up similar trends that many of the trials are not great. The functional results of leaving them or fixing them over a population of patients is very similar. and a very high rate of complications, particularly screw penetration, which I think we need to put into the mixing pot if we're considering fixing a lot of these. There is a trial that hasn't reported yet from the UK, a pragmatic trial of non-operative or operative, and the operation being the operation of choice for that patient and that surgeon, and that's yet to report, and maybe that will help us a little bit along the way. So implant problems. Avascular necrosis is said to be approximately double compared with closed treatment. Non-union certainly occurs, and it's not guaranteed not to go on to non-union if you fix it. Malunions can occur. Many of us have seen fractures that haven't been properly reduced before the metalwork was inserted. And of course, once the metalwork is inserted, it then builds in and fixes that malunion, and that may not be what you want. Hardware problems. We can see screw penetration, and the data suggests over a big series of patients, and obviously different surgeons of different abilities, screw penetration is very high. And also problems with the metalwork or the greater tuberosity being malpositioned and getting impingement either by one or the other, which does seem to be quite a problem with fixing these fractures. So we could stop here. We could say there is no data to suggest that operating on these patients does anything other than cause an unacceptable rate of complications. And those are difficult to manage, many of those complications. So maybe we should just manage everything non-operatively and be done with it, and we'll do less harm. But I think we need to look in a little bit more detail about what the aims of treatment are. We need to know something about the joint surfaces. I've called macrocongruency getting the head to match the glenoid in terms of its orientation relative to the glenoid, whether it be varus or valgus. And microcongruency about any steps within the joint, the head-splitting fracture. But we have no idea how accurate we need to do that to get a good result from the patient. We intrinsically think that if the X-ray looks fantastic, the patient will do well. But we don't know that. Pain relief is clearly important. And pain relief can be great from operating on patients, particularly those that are really struggling with getting night's rest because their arm is uncomfortable and it flops back and they can't control it. We need to have a little bit of thought about healing, and Ralph Hurtle's clearly the expert on that, looking at blood supply and the soft tissues. And function, restoring the function of the rotator cuff, and tuberosity positioning is really a surrogate measure of rotator cuff function, as Simon was alluding to earlier. We need to have a little think about how will the patient be able to comply with rehabilitation. It's my view that rehabilitation and cuff function are the two key things in managing proximal humeral fractures. And if the patient can't comply with getting the shoulder moving, they are going to get a bad result in the long term. And they have to regain an acceptable range of motion. And acceptable is not us measuring it at 180 degrees or 45 degrees of external rotation. It's what the patient can do in terms of their ADLs. And interestingly, most of the shoulder scoring systems measure ADLs as opposed to measuring absolute range of movement. And I think that's far more important for the patient. They tell you that they can't do their bra up behind their back. They don't tell you that they lack 10 degrees of internal rotation. And most of all, do no harm if you're going to operate. So we need to assess our patient, the patient who's in front of us. Identify the fracture, and Ralph Hurtle's Lego model is a fantastic way of thinking about that, characterising the pattern, thinking a little bit about the blood supply, and then, importantly, thinking about the patient. How are they going to respond to the operation? How are they going to cope with the operation? Predict how you and your implants will perform, and predict if you can manage the complications of doing an operation. Rehabilitation is about pain relief, about getting them moving early, about stability of the scapular setting exercises and stability of the glenohumeral joint, and then moving on to activities of daily living. And remembering many of these patients are elderly, many of them live alone. Being able to do a basic level of activities of daily living will be what allows them to go home and continue to cope independently, or may determine whether they need help or indeed end up in nursing homes or residential care. So predicting how your patient's going to cope has a number of things like age, mental state, comorbidities, pain as perceived by the patient, and their social care status. And that may differ from country to country. In the UK, many elderly patients live alone. in other communities they may get a lot of support from younger members of the family. If we look at the implants that we have available for treating these fractures in terms of non-operative care, essentially we have the collar and cuff using the weight of the arm. I don't like hanging casts. I think they're really unkind to elderly patients and they hate them. And the polysling or Velcro bandage, which more supports the arm and takes some of the weight off it. So if you're going to use a polysling or Velcro bandage, that effectively is lifting the arm up, supporting the weight of the arm and not really pulling the tuberosities apart. The big problem that patients have with these is night time. So they're fine when they're standing, the arm sits in a very comfortable position. As soon as they want to lie down, the arm slumps backwards and they find it very uncomfortable. So teaching them how to get comfortable at night in terms of forming a cushion of pillows to be sat up a little bit with a pillow or cushion underneath the shoulder here to stop it flopping back makes it immensely more comfortable for the patient and often enables them to cope with non-operative management. Likewise, the collar and cuff, there the weight of the arm is suspended and obviously that's drawing the fracture fragments down, may be appropriate for some patterns of fracture but not all patterns of fracture, and one has to be quite careful about deciding which fractures one puts into which device. So if we look at this patient, a 55-year-old lady, Ralph would classify that very easily for us, but we can see here is a fracture here, a fracture of the greater tuberosity. Now I would say in this lady that this greater tuberosity fragment and here is the bit that worries me most, that it's going to get poor cuff function and it's probably going to impinge if it heals in that position. So those two factors there would make me think that I wanted to operate on this patient, not treat them non-operatively. So to my mind, most fractures of the ones we see coming through from our emergency rooms can be managed non-operatively unless open fractures or neurovascular compromise are extremely uncommon. Displaced fractures of certain sorts, the head split, some two-part fractures, such as where the shaft is totally off-ended and don't get sucked into ones where x-rays are inadequate and you can't see where the shaft is, or significant displacement of the greater or lesser tuberosities, where they're either going to get impingement or poor rotator cuff function, and some 3- and 4-part fractures, depending on how much the head is displaced from the glenoid. The other indication I have is not usually a first consultation indication, but when the patient comes back at 2 weeks and tells me they've had no sleep for 2 weeks because the arm is still so painful, is pain. So in my hands, I think it's important that you understand the fracture and very particularly you understand the patient who that fracture is in. I default to non-operative treatment unless I can think of a good reason to operate. I can actually feel that I can deliver the goals of operation, and with osteoporotic fractures that's not always possible, and that I feel that I can manage and explain to the patient about any complications that may ensue. If you're going to do it non-operatively, do it properly, be prepared to rehab the patient appropriately, and also have a plan B, which means if things are going badly, to reconsider the role of operative treatment and use imaging to help inform those decisions. Thank you very much.